without further ado, let me introduce some members of our team. First of all, myself, I'm Bristi Basu. I'm an academic medical oncologist at the University of Cambridge, and I co-lead the Pancreatic Cancer Programme at Cambridge with Giulia Biffi. Giulia, do you mind introducing yourself?
Yeah, thanks, Bristi, and welcome everyone. My name is Giulia Biffi. I'm a group leader here at the Cancer Research UK Cambridge Institute, and I co-direct the Pancreatic Cancer Programme with Bristi.
Can we have Pippa, please?
Hi, I'm Pippa Corrie. I'm a medical oncologist here at Addenbrooke's, which means I'm basically the kind of doctor that gives anti-cancer drugs to try and treat the disease.
And Asif?
Hello, everyone. I'm a consultant surgeon dealing with pancreatic diseases and liver diseases. I'm part of the team that operates on pancreatic cancers in Addenbrooke's Hospital in Cambridge. And
Jill?
Hi, I'm everyone. I'm Jill Barker. I'm the HPB oncology specialist nurse based at Addenbrooke's. Work with the rest of the team with the patients when they come to the pathway on the oncology side.
And Laura?
Hi, I'm Laura. I'm a pancreatic cancer dietitian. So I help people with pancreatic cancer with suggestions with eating, drinking, problems they might have there with their pancreatic enzymes and some aspects of the diabetes and other things.
Can we have Nicola next and AD?
Morning, hi, my name's Nicola and I'm a clinical specialist physiotherapist in oncology, rehab and exercise here at Addenbrooke's. I run the REACT programme, which is our rehab and exercise activity during Addenbrooke's cancer treatment, so offering exercise opportunities and physio rehab to patients, all patients or any cancer types during their treatment journey.
Hello, my name is Aideen Martin. I am the surgical physiotherapy team lead here in Addenbrooke's in Cambridge. So I would see patients post-operatively on their rehab pathway.
And Frances.
Hello, my name is Frances. I'm one of the palliative care clinical nurse specialists, and I'm involved with pancreatic cancer patients either during an inpatient visit, so if they're admitted for acute issues, also for the enhanced supportive care role, so to have contact with patients earlier on in their diagnosis and their palliative care journey.
Thank you. And most importantly, Jim, can you introduce yourself? Thank you.
Yeah, right. Good morning, everybody. I think I'll start off by saying this is not my normal hair colour. My hair and beard were dyed purple for today and as a fundraiser for PC UK. Other than that, I was diagnosed with pancreatic cancer 6 years ago and subsequently underwent a distal pancreatectomy and splenectomy at Addenbrooke's. And as you can see, I'm currently doing very well.
We're delighted to see that, and we are actually very, very lucky that at Cambridge we have some fantastic input from a number of PPI representatives. Kate is behind the scenes and as the Cambridge CRUK Cambridge Centre banner, and she's our programme manager, and I think she will tell us a little bit more with Giulia later on about other events happening locally within and regionally within Cambridge on this World Pancreatic Cancer Day. So we actually had significant numbers of questions, and I will try to bunch them into themes, and I apologise if I can't go through all of them, but we will try and address as many as we can today, and please feel free to ask more questions as well. I can see that there are 51 participants, and that there are a whole group of people from diverse sides of the group who are interested in pancreatic cancer, either on the clinical aspects, directly, personally, having experience of pancreatic cancer themselves or through their loved ones, managing patients, also on the research front as well. So we welcome you all, and we want to get as many questions which will tackle the holistic aspects of dealing with this really difficult cancer. We know that it has one of the lowest survivals of all common cancers, and it's becoming increasingly more common. A 5-year survival is less than 7%, and we know that early diagnosis is pretty crucial, but we are we struggle with this because it presents with non-specific symptoms and is often picked up late. So some of the questions that came through to us were regarding access to treatment and the treatments which are available, and when we might consider patients for surgery, for instance. So I thought I might just start off asking Asif, what are the considerations that there are for deciding on resectability or operability of these cancer patients?
Thank you, Bristi. So, pancreatic cancer, like many other cancers, are obviously highly dependent on whether they can be removed or not. Surgery is the key part of that treatment, the mainstay of the treatment. So, if you can remove the pancreatic cancer, that is best thing for the patient. Unfortunately, what we see is that the majority of the cancers, the pancreatic cancers that come through to us, are already not resectable, i.e. They cannot be removed. And there are two aspects to it. One is that the cancer might have spread to other organs, distant organs, which we call metastasis. So even if the pancreatic cancer is small, and if it has gone into liver or lung or any other tissue that we can't remove, then obviously that cancer is not amenable to removal, because even if we remove the main pancreatic cancer, we'll be leaving cancer spread elsewhere. So one is the distant spread. The second part, which we do struggle with and try and assess and give the benefit of the doubt to the patient as much as possible, is the local spread. Pancreas is an organ that is set between lots of organs, lots of very major blood vessels that are key for survival, such as the blood supply going into the liver, intestine, and so on and so forth. So the second aspect is what we call as locally advanced pancreatic cancer, which means that although it's not spread to distant tissues or organs, it is just too big or involving just the wrong or key structures where it is. And if we cannot remove all of it, then it is futile to remove only part of it. So in other words, for example, if it is involving the blood supply going into the liver, it is too much of a surgery, too much of a risk to remove all of that and the cancer. So when the cancer is locally advanced, or it is too complex or too big locally, that also we can't remove. So all of these things are determined by a very thorough staging procedure. We spend quite a lot of time on staging to make sure that we detect the right individuals that have resectability. As I said earlier, we give the benefit of the doubt to the patients as much as possible and try to resect them, because it is the key to treatment. But sadly, vast majority, to the tune of 70%, perhaps, if we push it more, maybe 60% people are still unresectable at the time of diagnosis.
Thank you very much for that. Well, I actually had a very specific and early question, actually, but even before that, which we will answer live. What does the pancreas do? Laura, why don't we start with you? Are you able to help us with this, please?
Sure. So the pancreas has got two main roles in the body, and they're all involved with dealing with the nutrition that we eat. So there's the pancreas produces enzymes that mix with the food that we eat in our bowel to break it down into pieces small enough that we can absorb it through the wall of our bowel, and therefore it nourishes us. If we don't have those enzymes, then the nutrition we eat goes in our mouth and stays in that tube that goes through us, and we pass it down the pan rather than absorbing it into our body. And then the second role of the pancreas is to deal with that nutrition further down the line. So it produces hormones, and the one people are most have usually more likely heard of is insulin, but it produces 4 hormones that help us to deal with the carbohydrate we eat and the level of sugar in our blood.
Okay, thank you very much for that. Actually, Jim, I was wondering whether you'd mind telling us, well, what were the symptoms and the your signs that you had pancreatic cancer? Because as Asif has mentioned, it's quite difficult sometimes to get these symptoms as a specific sign of cancer.
Yeah, I mean, I agree with you. I think this is one of the sort of key things, because to be honest, I've probably been feeling unwell for quite a few months before it was discovered, but with nothing that you could really put your finger on as being an issue. I was feeling unwell, not myself. I was losing my appetite. I was getting sort of strange, odd pains, not just nuisance pains to the left side of my ribs, sometimes in my back. Particularly when I was in bed, laying in bed, I'd feel some pain in my back, but nothing enough to really think there's something really wrong. Just think, what is just going on here? Is it old age and pieces like that, or is my heart playing up? I'm getting pains on the left side and that. But it was very sort of non-specific. I think then I just started to lose my appetite, and I was losing weight, and yeah, waking up in the morning as exhausted as when I went to bed. So that's really when I think, it came home to me that this needed looking further at, and I went to see my GP, but I did put off seeing my GP for several months.
Yes, and I think that's quite common, isn't it? Because some of the symptoms you mentioned are very non-specific, aren't they? I was just wondering if Jill or Francis could mention any of the other symptoms that we commonly kind of come across in our patients.
Yeah, I think it's just been said, they're very sort of, they are non-specific. People attend, but they also get pain, like the gastric reflux, fatigue, sort of radiating pain to the back. So these are the main sort of issues. I mean, on severe cases, if there are problems, patients can go jaundice. But I think we're looking at sort of the main sort of element is discomfort and sort of generally feeling unwell, and maybe bloating. They seem to present with.
Francis, was there anything else that you wanted to mention at all?
I don't think so. I think early on, I don't have that much contact with patients early on with the symptoms. So I think probably the things that Jill is seeing.
Okay, and so yeah, I think some of the common ones which have been mentioned: tummy pain which goes to the back, unexplained weight loss or loss of appetite, a change in bowel habits, as Laura has mentioned. Pancreas is so specific, it's so important for the bowel function, indigestion as well, and also jaundice. Some people just complain of itchy skin, and one of the questions I think submitted was why does pancreatic cancer cause itching? That's from Jenny in Suffolk. Have we got any answers from Laura? Is that all right?
Can do. Why pancreatic cancer causes itching?
Yeah.
Because of the jaundice, which is the bilirubin, which is something that the level that would build up in your blood, and then that would cause itching. I don't know the exact process of how the itching's caused, but that building up in your skin would give you jaundice. Asif might have a more technical response.
I think that's plenty. It's the bile salts, isn't it, that are accumulating under the skin, causing it itching. So okay, so actually, in terms of the symptoms that often present, and I think that sometimes, although a tumor might be technically resectable, operable, patients aren't well enough to have kind of the treatment. And I'm just wondering whether we can get some advice from Jill, Laura, Nicola and Aideen about how we optimize their performance status, prior to considerations of any treatment. And I'm happy to ask Nicola first.
Well, thank you for that. Yeah, absolutely. So we've already heard that actually there can be a deterioration in an individual's well-being in this run up to the diagnosis. So often when the decision is made for surgery or for chemotherapy, that patient isn't necessarily in their optimal condition, that they have become deconditioned. And there is certainly a concept called prehabilitation or prehab, where we can try and get that patient as well as we possibly can. We can optimize them for their surgery or for their chemotherapy, so that there's the best possible surgical outcomes, there's the shortest length of stay possible as well, and so that they can recover well following their surgery. And we do get involved with offering prehabilitation for the individuals. It's sometimes the exercise guidelines can be quite daunting for these patients though, and sometimes you see all of these guidelines about moderate intensity exercise and what have you, and actually for that patient group it can be quite overwhelming. So we often start from a slightly lower level, if you like, and we start getting that patient to think about reducing their sedentary behaviour, starting to be more physically active around the house, around the garden, doing other activities with their friends and families before they start to sort of become more au fait with exercise. And that's when we try and build in the guidelines. We don't want patients to run for the hills straight off the bat, but yeah, so there's very good evidence for this prehabilitation to optimize patients ready for their treatment.
Aideen, do you want to add to that?
Just to echo what Nicola was saying, it's also never too late to start. And I think that's a really important message to get out today. In terms of exercise, all exercise can be modified towards the person and that individual. Another element that we look at from a prehabilitation point of view is also breathing exercises and trying to optimize patients from a lung function point of view as well.
We have Jill raising her hand as well to us.
Yeah, I think often when you see patients at the beginning of the journey, maybe sometimes I find it's even when you're visiting them on a surgical ward, the main things I think to optimize is obviously they've lost weight, is their dietary input, but also psychologically I think we need to work on, it's obviously a shock diagnosis, it's trying to sort of help get the head around it, and you know, family members as well. I think if they're not in the right place mentally as well, it's going to be a hard thing to begin the journey and sort of want to build themselves up in a dietary way, and help with fatigue, etc. So I think it's really important to mention that.
Maybe can I ask Laura first to talk about diet, and then maybe we can address some of the resources that people can access to help support them through this.
So in general, what people would need. So various different people have mentioned various symptoms that people get when they have pancreatic cancer, and a lot of those would impact on someone's nutritional intake for a variety of reasons. So if you're tired, it's harder to go shopping, it's harder to prepare food, it's harder to want to eat so much. If you have a change in bowel habit when you eat, then that can put you off eating. So there's lots of reasons why people might eat less or might modify what they're eating. Our primary goal, I suppose, in helping to nourish people is definitely to support people in being able to eat enough, but really initially helping their body to deal with the nutrition that they do have. So that's the pancreatic enzyme replacement. So I mentioned earlier that one of the roles of the pancreas is to produce these digestive enzymes. And if the pancreas isn't producing enough, or because of a tumour they're blocked from getting into the bowel, then we can replace those in a capsule, so people can take these pancreatic enzymes, which actually come from pig pancreas, to be able to digest what they eat. So sometimes people don't actually need to eat any more to stop losing weight, they just need to be able to deal with the food that they are having. Or if maybe they have undiagnosed diabetes, which means that your body can't deal with the carbohydrate that you're eating and the level of sugar in your blood goes really high, then you lose weight because of that. So helping people to so that we can identify that and then treat that as early as possible is most helpful. And then people can get all sorts of individual side effects either of the cancer or its treatment, and then we would look at those. So maybe their stomach is taking a bit longer to empty and they need a liquid diet, or maybe they have a sore mouth, or finding swallowing hard, or any sort of range of things that people come with, then we make a sort of bespoke plan for them depending on whatever their symptoms are.
Thank you. And was there anything from Jim or anyone else about that side of things?
Yeah, I mean, a lot of this sort of rings true really with what has already been said, and in particular sort of things that sort of Laura has mentioned, the loss of the appetite. And my wife would be putting my favourite meal in front of me, I would eat a few mouthfuls of it and I felt full up. And you can imagine how well that goes down at home, but it was those kind of issues, but it was all non-specific and I was sort of losing weight. At that point, then we didn't know what was going on with me, but, and my GP surgery, and I'm no criticism of them whatsoever. They didn't initially make this link because it is such a difficult thing to pick up on. Blood tests had confirmed that I'd got high blood glucose levels, so it's assumed that I'd become type 2 sort of diabetic. Well, with hindsight, you can see that this was causing the diabetes, and it's only from the follow-ups and the time I spent with the diabetic nurse at GP surgery when my blood sugar levels were still not dropping, when finally the alarm bells rung, and the investigation for the cancer started. But yes, and building yourself up, I can wholeheartedly agree with that. Okay. The emotional build is the key thing, I think, really. Having some positivity and belief that, you can come through this.
Thanks, Jim. That's really important. Okay, so I think there was a question from the audience about how common a metastasis is in pancreatic cancer, and how common advanced diseases. We've addressed some of the early disease where there might be resection options. Pippa, I was wondering whether you might kind of start to talk to some of the more advanced treatment options, the treatment options for more advanced cases of pancreatic cancer and how common it is.
Sure. I think as Asif actually alluded to at the very beginning, unfortunately, and partly because of the non-specificity of the symptoms that patients get with this disease, the majority of people are actually diagnosed with advanced disease. And that's something that clearly we are very much focusing on from a research community as to how we can change that, and we can get onto that later. But yes, at the moment, we have a high proportion, 2/3, 3/4 of all pancreatic cancer patients are diagnosed with advanced disease. And that's either a locally advanced tumor, as Asif was mentioning, the primary tumor is too big to get to remove, or there is spread to other disease sites, to body organs. And the common places that pancreatic cancer spreads to is the liver. It can spread within the abdomen. More rarely, it can go to the lungs and elsewhere. But it's usually the extensive spread to the liver, which is the major problem. So people like myself and Bristi, as oncologists, spend a lot of time giving anti-cancer drugs or chemotherapy to try and treat this disease. But what we've been finding is that by comparison with the leaps and bounds of improvements that have come over the last 10, 20 years, particularly in terms of the new types of drugs that we're using based upon a better understanding of the biology of the disease, we're still struggling to really make inroads in pancreatic cancer. So we still use conventional cytotoxic chemotherapy as our standard treatment. It can achieve disease prolongation, but it doesn't cure. It has limited benefits. Ultimately, the cancer will grow despite the treatment we give, but it can also improve quality of life and pain control, things like that. So it's definitely worth using. And clearly, there are some people who do better than others, and we still want to learn from that. And we can talk a bit more about how we are trying to enroll people all the time in clinical trials and programs of research where we can learn from patients. And in the UK at the moment, we have a program called Precision Panc, which is all about trying to learn from that initial tumor biopsy about the molecular insights, the genetic changes that may be dictating the behavior of that cancer, so that hopefully we may be able to identify specific pathways that we can target and block directly with the more modern molecular types of treatments. And so Giulia may want to talk about some of the science But what we're very keen to do is to engage with all our patients, to encourage them to take part in these kind of trials so that we can improve outcomes, if not now, but certainly in the future.
That's really well summarized, and I think there were questions actually submitted about precision oncology and whether around the UK is being offered. I think Georgina from Cambridge had asked that, and you've addressed that actually there is a UK national precision panc infrastructure which has actually built up mechanisms to get the tissue and get it sequenced. It's still early days in terms of trying to find ways to tackle these changes when we find them and find the appropriate trials for them, but we are making some inroads into that. So some of the other questions kind of within that theme are, obviously, as you've mentioned, pancreatic cancer is often resistant to drugs. What other treatments are available or being researched, and how do you foresee treatments for pancreatic cancer in 5 to 10 years' time? Those are questions submitted by Georgina and Sally in Cambridgeshire. I was wondering whether, Giulia, you wanted to make a start from the lab side of things. What sort of things are looking exciting from that side of the treatment aspects?
Yeah, so I think what we are looking at is various levels. One is still we need to understand better the biology of the tumors because we are quite behind compared to other cancer types. And the other thing is we need to understand how the tumor will respond to the therapies that we are using. And so we are using laboratory models across different laboratories in Cambridge, and we are also looking at patient tissues to understand these two things. And in particular, a lot of efforts we're trying to do is to look at the tumor as a whole rather than just at the cancer cells, and how different cell types in these tumors are contributing to the progression and the dissemination to metastatic sites of the cancer cells. And then, of course, we are also working towards early detection, but I think we can talk about this when we...
Yeah, we've got several questions about that later, but yes, I think you mentioned about precancerous tissue and trying to learn a little bit more about that. And there was a question from Claire in Berkshire about, what kind of research is being conducted on precancerous pancreatic tissue. I'm aware, Asif may want to speak to this as well, that one of our colleagues, Anita Balakrishnan, who's a surgeon, is actually looking at pancreatic cysts and looking at the cysts which might develop into, have more risk of developing into pancreatic cancers, and trying to look at the biomarkers within those cysts. I don't know, Asif, whether you wanted to say anything to that as well.
I think that's right, Bristi. So there is a lot of work going on in early diagnosis, particularly for high-risk cancer patients. So as you mentioned cysts, one of my colleagues is looking at it. There is obviously work going on in trying to get early diagnosis for people that have family history, a strong family history of cancers, or indeed they have genetic mutations that are part of cancer syndromes. Ms. Balakrishnan also is looking at circulating tumor DNA and that sort of thing. So there are lots of work going on in early detection, but they are still very much in the lab rather than in the clinic. So the application is still some time away.
So I think that there are, to answer Claire's question about research being conducted on precancerous pancreatic tissue, there are efforts happening, and actually even in the Sanger, I think they are going to be looking at pancreatic tissue, which might not have cancer, and also in patients who just to look at field changes to the genetic kind of molecular profiles within some of the non-cancerous tissue, just to work out whether they can learn a little bit more about that. So there is some interest in finding out why these cancers are developing. Maybe we can start to look at the question, actually, because there have been several questions about biomarkers and how we get this cancer earlier, which is so important, because we really want to get this cancer so we can cut it out and give treatments so that we can cure it, and we're not in that position yet, because frequently it's beyond resection. So in terms of that, I mean, I think Pippa, you were aware about the GRAIL study, and would you mind speaking to that a little bit, and I can say a little bit more as well.
Yeah, so definitely, clearly, you know, I think everybody is completely agreed that we really do need to have a concerted effort to try and diagnose cancer, pancreatic cancer, but all cancers earlier. And that's good for patients, and it's good for the health service as well, actually. And there is a lot of work out there which is growing through scientists and biotech companies, all sorts of people working together. And NHS England is part of a strategy alongside the National Institute for Health Research in promoting research in this area and clinical studies. And just one example, it's not the only one, but there are a number of these kind of studies out there now, is the use of picking up bits of genetic material that is released into the blood from tumours. And we call this circulating free DNA. And this can be detected now. There are some fabulous scientists who can do this. We've got people in Cambridge, but across the world, this is a huge area of focus. And in this particular situation, a company called GRAIL, and you can go onto their website, GRAIL, and they have lots of information there, has teamed up with NHS England and the NIHR, and is basically conducting 2 large-scale trials. One which is about population screening, literally just taking a blood sample from individuals in the community coming through GP surgeries to try and identify cancer in asymptomatic people. And then there's another study called Simplify, which has been, and is just coming to its fruition at the moment, completing recruitment of 8,000 individuals who have, as we've discussed today, rather non-specific symptoms, who are being referred in through their GP to what we call rapid diagnostic centres. And those people who are going through the standard diagnostic tests, endoscopies, biopsies, scans, and so on, will also, again, just have a simple blood test. And the idea is then to be able to correlate the outcomes of all the tests with whether or not this blood sample will be able to detect the cancer. And this is looking across multiple cancers. The initial work that they've done with the GRAIL test, they were able to identify up to 50 different types of cancer. And there was a very strong correlation with disease stage. So they were able to pick up very easily advanced disease, but they were also able to pick up early stage disease. So the idea is if we can shift from being able to pick up earlier stages of disease, we will get more people to ASIF for surgery, and we will have hopefully fewer people coming through to me and Bristi. So I think, you know, that's the whole concept. Those studies will report quite quickly, I think, in the coming year or so. So literally, we're talking a simple blood test to replace a whole gamut of complex diagnostic tests and so on. It's very hopeful at the moment. I think we just have to keep our fingers crossed that the results are good.
Thank you. And actually, you know, as Pippa mentioned, there are a number of efforts in this field. There have been a number of questions specifically for this. So it's clearly a really important area of research for our community, who are, you know, are interested in pancreatic cancer. So some of the questions are: I have been diagnosed with pancreatic cancer. Is there a test members of my family should consider with a view to early diagnosis? From Fran in Cambridgeshire. Is there a screening blood test that I can have for pancreatic cancer? That's actually from Lindsay in Warrington. To help earlier diagnosis, could a research trial give a liquid biopsy and access participants' health records over an extended period of time for the high-risk groups? That's from Georgina in Cambridge. All of these things are actually happening in different spheres. So actually, in terms of the family history, it's as has been mentioned a couple of times, there are certain groups who are potentially have an inherited tendency for pancreatic cancer, and we know that if you currently the testing criteria, if you should be referred to genetics if you are have pancreatic cancer under the age of 60, or if you have pancreatic cancer under the age of 70, but you have breast cancer under the age of 60, melanoma rate under the age of 60, or ovarian cancer, or first or second degree relatives with pancreatic cancer under the age of 60, or 2 first or second degree relatives with any breast cancer aged under 60, melanoma, or ovarian cancer. And that's because of some of the genes that are implicated in the familial pancreatic cancer. So the inherited types of pancreatic cancer, BRCA2, CDKN2A, for the FAM syndromes. So there are groups where they actually are counseled by genetics and have sequencing done to see if they're carrying this. And there are studies which are kind of led by Liverpool, the EuroPac study, which is a large kind of study being run within Europe and the UK, looking at certain ways to investigate these people who don't have pancreatic cancer but have potential high risks, and they do it through blood but also through endoscopy and imaging. Now, one of the ways we really want to try and bring this more widely to people in the public is to make these biomarkers non-invasive. And so to that end, Pip has mentioned the blood testing within the GRAIL study. We have also a study which I believe is, it was actually only earlier this year, where there was a PanFAM1, which was looking at the IMRAE PanCan-D test, which was looking at some kind of a signature produced by the pancreatic cancer, which resulted in an antibody signature when you run it through a panel. And that has actually been validated in the UK population. So it's being tested, and I suspect that it's being commercialized. So we will potentially hear quite within the next year or two how that's going in terms of wider adoption as well. Also, I think John from Essex has asked about EuroPanc. That's spelled UROPanc. That's a study which is being run from Barts with some funding from PCRF. And they're looking at 3 biomarker signatures within urine, and they're trying to test it in a few thousand patients to look at potential patients with high-risk features and symptoms versus other populations. So this is a very active area of research, because we actually completely get why we need to detect this cancer earlier. I think that there's no question that we see that as a priority. And that's something we're doing at Cambridge. It's something we're doing nationally and internationally, and we try and join the dots. Okay, so I think there were some other questions regarding that. Actually, I think we've answered about the PALB2 mutation. So that PALB2 is seen actually in pancreatic cancer as well, and generally that would be those patients might be referred to the EuroPac study, which is EuroPac study which is being run from Liverpool but has different sites within the UK. The closest to us, I think, is actually in London. Okay, so I'm just looking through. Does anyone else want to answer any other questions? Oh, this is a really kind of important question on the B part of research. This is an anonymous attendee. B part of research website, there are currently 38 pancreatic cancer studies. There are 147 breast cancer studies. Are there plans for further funding and research into pancreatic cancer? Well, we really think that it should be. It should be. I think traditionally there's been a bit of a feeling of nihilism around this cancer, because it's easy to understand when we haven't made massive inroads into the kind of survival outcomes. They really haven't changed very significantly for decades. I don't know if Giulia would like to say something about this.
Yeah, as you said, we haven't really made much improvement. Definitely, there's way more research than there was 20 years ago. We can see that. We still have a way long to go to make better models in the labs that better recapitulate what we see in the patients. And I think when we get there, we will be able to translate what we find in the lab to the clinic more quickly. And this is also what is great about Cambridge, is that there's a lot of collaboration between the academics and people like me in the lab and people like Bristi in the clinic. And we keep communicating about priorities for the patients and how we can make waves.
Yeah, thank you. And actually, we really need patient advocates. We really need the public to prioritize this and tell funders this is actually something we need to work on. So we're all part of the same community, and we all want the same aim, which is to improve the outcomes of pancreatic cancer. Okay, so there are several there are several questions coming through which are quite similar on the genetic aspects, and I think that the guidelines, if you actually access the EuroPac registry website, they will have certain guidelines on how you can be referred and whether you meet the criteria for those sorts of studies. So I've just answered the question from Fran and from anonymous and attendee, which I think has addressed that kind of aspect. So I have something from Roy. Thanks for a great webinar from a 7+ survivor of pancreatic cancer with 1 out of 13 lymph nodes and 6 months of gemcitabine. That's fantastic. We're so delighted. Long may your health continue. And actually, we did have a question from Sally in Cambridgeshire about. I believe that she's done very well with her pancreatic cancer diagnosis, exceptionally well on FOLFIRINOX. And why is that? What makes her tumor special, or her special? How do we find out about why certain patients are going to be more sensitive to some of the treatments which are adopted in clinical practice? So Pippa, maybe you can start here, but we're very happy to.
Yeah, I mean, I think this goes back to the understanding that, not all cancers are the same. And traditionally, we have literally boxed people into, well, this is pancreatic cancer and we treat it this way. This is breast cancer and we treat it this way. And what we've absolutely learned over the last 10, 15 years is that this is really not the case. And that at a molecular, because we're looking under the microscope at a it's still microscopic, but it's at a sort of a cellular level. Everything looks the same. But when you get people like Giulia looking at the molecular level, the nitty-gritty genetic makeup of the cancers, then you see lots and lots of variation and differences. And this is when this concept of precision medicine comes in, that we actually really need to understand the individual personalized tumor so that we can hopefully, and I think there were some questions around this, generate personalized medicine for the future. And so if we take FOLFIRINOX, for example, there's a number of different drugs in there, but we do know that these drugs were working in different ways. And one of the possibly the key drugs in that combination is a drug called oxaliplatin. And these platinum drugs are working in a particular way to cross-link DNA and stop it functioning in the normal way. And it may be that there are a certain set of genetic changes that are actually predisposing to that particular type of chemotherapy being effective. So if we can actually characterize each individual patient's tumor and identify those people who have, or those tumors that have those changes, maybe we can actually push those people into them being the ones that have FOLFIRINOX or platinum-based chemotherapy. And this is the basis of, again, one of the trials in the Precision Panc program, Primus 001, is very specifically looking to see if we can identify a particular genetic signature that actually will predict for platinum-based response. So it's this kind of thing that we are working towards. At the moment, we just, we're in that process. And hopefully in the coming years, we will be able to get the answers that we need so that we will hopefully be able to start personalizing people's treatment. treatment.
Thank you. And I think, you know, one of the questions which came from one of our anonymous attendees is, how do I know if I'm suitable for one of these trials? It's okay to ask. It's okay to ask. Ask your oncologist, ask your GP. There are resources, the Pancreatic Cancer UK, Cancer Research UK, sites as well, which might direct you to where some of these research studies are being done. So please don't feel that because it hasn't been offered necessarily, that you're not right to ask. Please do ask. Okay, so actually, I think we've talked a little bit about treatments and how treatments might be changed in the future. Actually, I'm going to stay just for a couple more minutes on this before we draw it back to some of the symptom side of things. In terms of where research is going in the future, research investment in basic biology, and also, you know, I think where treatments are going in the future, we have to obviously understand that it's not just the pancreatic cancer cell which is the problem. You know, there is the surrounding cells, which I think is a focus of Giulia's work. We would also like to work out why some of the treatments that Pippa has mentioned have worked in other cancers, immunotherapies, for instance, why they're not particularly active in this particular cancer. Why is it that the immune cells just aren't within the vicinity, or the wrong immune cells are within the vicinity, and that means that you can't get your own immune system to work against the cancer? How can we actually work on improving that? You know, so that there are ways of bringing in other cells outside of the pancreatic cancer cell to try and improve that. I don't know whether Giulia or Pippa would like to mention anything about this. I know Pippa has a clinical study we're planning to open nationally in the next year, but Giulia's also got a very active area of research on this.
Jordan, I'll kick in and Giulia, you pick up. I think, as I'm also, in my other half of my life, I treat a disease called melanoma, and immunotherapy has absolutely revolutionized how we treat melanoma. And I think many pancreatic cancer patients often say, well, you know, why can't I have immunotherapy? Why isn't it a treatment for me? But the disease, again, is very, very different. And if you look under the microscope in melanomas, you see lots and lots of immune cells that are packing in there alongside the melanocytes. And also what you see at the molecular level is you see lots and lots of abnormal genes, gene mutations. And that's because in the case of melanoma, a lot of that damage to the skin generated by the sun, so sun damage generates mutations. And those mutations actually get our T cells really, really busy, because the T cells are the key cells in our immune system that are actually going to fight the disease and kill off the tumor cells. Now, in the case of immunotherapy, the kind of drugs that we're currently using called immune checkpoint inhibitors, they are actually enhancing the behavior of the T cells that already exist in our body. So if you have a tumor that is sitting there with lots of abnormalities, if you then charge up those T cells to get to work, you get a really good response. And that's why it works in melanoma. In pancreas, it seems to be completely different. So if you look at a pancreas, the T cells are not within the tumor. They're sitting around the tumor, so they're not getting into the tumor. So that's one issue. But the other thing that we're interested in is this number of genetic mutations, and we call this tumor mutation burden. If you look again in pancreatic cancer, although it's a very abnormal disease, the number of mutations is nowhere near the number that again we see in melanoma. But again, going along that concept, well, even if there's a subgroup of people who do have very high levels of tumor mutation burden, could we identify those individuals and then at least offer them an immunotherapy approach? And that's what we're trying to do in the study that I'm leading on, where actually through our precision medicine molecular profiling, we will be able to measure tumor mutation burden. And in those people that have a very high level of those mutations, we will offer them an immunotherapy approach and see whether, again, just by identifying a subgroup of patients, we can improve their outcomes at least. So it's just one other approach to how we can try and break down this concept of just giving everybody the same treatment.
Okay, Julie, do you want to maybe just add to that?
Yeah, so as Bristi mentioned, my lab works on the non-cancerous cells of pancreatic tumors. And that's because maybe surprising considering this is such a deadly disease, but the majority of the cells in a pancreatic tumor are not cancer cells, are fibroblasts that are cells that we work on in the lab and other immune cells. And we are interested in understanding how the cancer cells reprogram these non-cancerous cells, because we find that these non-cancerous cells protect the tumor, allows the tumor to grow, and prevents drugs to be effective in killing the tumor, both chemotherapies, but also immunotherapies. And the fibroblasts, which are the cells that we work on, actually have been shown to be responsible for this immunotherapy inefficacy. So even if there are pancreatic tumors actually that they have a lot of T cells, but they don't get close to the cancer cells because you have all of these non-cancerous cells that prevent them to get in there and be active and killing the cancer cells. And so the other thing is that while you have maybe 10% of the cancer cells and all the 90% is non-cancerous cells, this 90% is very heterogeneous. And we find that the mutations that Pippa was mentioning are affecting the heterogeneity and the variety of these different non-cancerous cells. And so that's why I really think that down the line, precision medicine would be key, because every tumor looks a bit different, not just because how the cancer cells look, but also how the non-cancerous cells look, and how a therapy will affect the cancer cells. It might also affect the non-cancerous cells. So we need to be proactive rather than play catching up, and be able to combine different therapies so that we can actually be effective in treating the disease.
Thank you so much. Those are really, really interesting questions and answers, I think. So I think we have to bring it back now down to reality in terms of what we have currently. We've got so many exciting things on the horizon, but many of our patients just don't get to any form of treatment. 7 out of 10, I think that was an absolutely devastating statistic that Pancreatic Cancer UK found, that 7 out of 10 people with this cancer don't actually receive active cancer therapy or treatments, and actually they're in their situation, they are for best supportive care, symptom control. I know that there are lots of questions on their diet because many of them are diabetic, and those have been a number of questions related to that. I was wondering whether, Laura, you could mention some of the kind of advice you might give in that situation.
So someone who is
diabetic and trying to maintain, intake when often they're trying not to lose weight, aren't they? But they have to watch out how to manage their diabetes as well.
So yeah, I believe it's about 80 or 85% of people with diabetes in this country have type 2 diabetes, which is often a very lifestyle linked disease, and the advice given out with healthy eating messages to people with diabetes is very targeted towards type 2 diabetes, and that's not appropriate for someone with pancreatic cancer. So most people with pancreatic cancer who have diabetes will have what's called type 3C diabetes, which is different from type 1, which is an autoimmune condition, and different from type 2, which is a metabolic condition. It has similarities with each, but it is different and needs to be treated differently. And if someone has pancreatic cancer and diabetes and they're given this healthy eating advice, then that's not appropriate, because they need to be nourished in a different way. Aiming for weight loss is not appropriate. So we have our exercise experts here, but still activity and using your muscles is appropriate, but in a different way, and not aiming to lose weight, as I mentioned. So sometimes people can get conflicting messages where they are treated by someone maybe in a GP practice or that hasn't come across 3C diabetes before and is used to treating someone with type 2. I mean, you can be overweight with pancreatic cancer and it's still not appropriate to aim to reduce your weight. So it can sometimes be difficult to give people the support. that is appropriate for them. We have written patient information literature that's available for dietitians, clinical nurse specialists nationally, doctors to help to support that. But that's definitely a work in progress.
Thank you. So I think we're going to wrap up in the last 2 minutes, actually, and try and get maybe Francis and Jill and Jim to mention what some of the support networks and structures that patients and families can access with this pancreatic cancer diagnosis.
Shall I go first? So within the Cambridge area, we run something called enhanced supportive care. So that's often for patients who are having some oncology treatment at an early stage. And the benefit of that is that actually you start to build up a rapport with the patient, with their families, with things that they may need now or they may be worried about needing in the future. And then we can refer on to other services if needed. And so it may be that there are no symptoms necessary at the moment, but it is something that people worry about developing in the future. So having that access to early palliative care is something that I think we need to spread out there much more.
Certainly. Jill, can you add to that at all?
I think we're quite fortunate in Cambridge. We've got quite a good support network. I think it's just sort of letting people know about it. Of course, we work closely with enhanced supportive care, but also so we do have other agencies like the Maggie Wallace Centre, etc., that provide support for the patients themselves, but also relatives, which is really important. And also there's sort of various charities, sort of, you know, smaller charities like the Elizabeth Copeman Fund provide support. But I think it's, you know, as we've mentioned before, it's looking at both the, you know, the psychological input and the physical, because it's really tough on both, and sometimes it can be, you know, quite a quick journey. So we need to sort of get involved quite quickly and all work together, which I think we do.
And I'd like to leave the last word with Jim, if that's okay, in terms of what support networks he's accessed and what's been helpful.
Well, I'd say when I was first diagnosed, I didn't know of any support networks and such things, and I realised how essential that would be, you know, the emotional and psychological load on yourselves. But currently, one support network that I'm closely involved with is with PC UK. It's called their side-by-side network, in which somebody who's been newly diagnosed with pancreatic cancer and is been referred for surgery can speak to somebody like myself who has been through the journey. And this is often the first person they've spoken to who they know has survived this terrible disease. Now, so that is a huge support to this person. And over the phone, you can often almost hear the weight being lifted off their shoulders, that actually there may well be a light at the end of this tunnel. I think that is the key thing. People need that kind of positivity, which then helps them when they're going forward into surgery and the rest of the trip, having some hope. Because when I was first diagnosed, I'll be honest with you, I couldn't see Christmas ahead of me. And that's the important thing, giving people that hope. Hope and belief is the key thing here, I think.
Thank you so much for that. That was a really wonderful way to wrap up this. And I think, yes, we want to get away from the nihilism. We're so committed to improving the outcomes for this cancer. And World Pancreatic Cancer Day is a great time to focus our minds on how this is going to happen. There are several events happening locally and regionally. We will have on our Twitter page and also our website how you can access some of these. We had so many other questions coming through. I wasn't able to get us to answer all of that, but we will try and address a few of them either via Twitter or via our website where we can. But I just want to say thank you so much to all of our wonderful panelists here. Thank you to the other supporting members from PPIE and Amanda Stranks from PC UK, Anna Lakey, Reese Grant, our Cambridge Science Communications lead, and Jim, certainly for your voice as well today. We hope it's been useful. We hope to do this again sometime, and we'd love to have some feedback from you, but hope you have a very good day. Take care.